So we talked about Arano, we talked about Aerosens and the Peace One trial. Let's now talk a little bit more about radiation oncology. How do we fit radiation into our treatment with high volume disease and low volume disease? Are we consolidating patients? What do you talk to your patients about?
So, I think there have been a couple game changers in metastatic prostate cancer. I think the advent of ARPIs have made a huge difference, and then metastasis-directed therapy, I think, is also one of these avenues. So for us in radiation oncology, if we see a patient with metastatic disease, obviously we'll need to see, their burden of disease, high volume, low volume, looking at some trials, like David mentioned, charted 4 lesions, Stampede, look at 3 to 5 bone lesions, et cetera. And how do we approach those patients from a standpoint of, do you go forward with metastasis-directed therapy somewhat upfront, or if they're high volume, do you see how they respond to systemic therapy agents and reimaging and see whether, oh, well, these guys have cleared a lot of their disease, but there's maybe a few residual lesions, and should we look at targeting those areas? Definitely in the low volume disease, there's very compelling data, Stampede, Oriole, Sabre, Comet, which looked at other histologies, but in the prostate cancer group, significant progression-free survival in those patients, which also allowed continued duration of the current agents that they were on. So you could hold your salvage treatments for a later date when they progressed. So I was an early adopter of that, and with the stereotactic techniques that we're using now, very focal radiation, minimal exposure to surrounding tissues, very well tolerated. Doesn't impact their ability to continue ARPIs or even docetaxel for some of these patients that are responding well during treatment.
Okay, so for my 2 medical oncologists, when would you refer back to Dr. Patel here for consolidative radiation to the prostate primary? Is it, case by case? Is it high volume, low volume?
Yeah, it's definitely case by case. I think general high volume is not the patient that I'm sending, right? So I'm wanting them to be on, at least the bare minimum doublet, of the hormonal type therapy. And typically it's at least years on that in my clinic. I mean, I know there are some studies looking at even at a year, with low volume disease, trying to back off and say, let's do, directed therapy with radiation oncology. I think we'll see what those results show. In the place where I've observed this, and then patients maybe went to like a Cleveland Clinic or some other tertiary center and got single site metastatic directed therapy. I've had a few failures already in my clinic. Just over time it does come back, and we end up treating more aggressively again. So.
For me, I would say that I usually, if low volume disease, certainly consolidate. I think they do better locally if there's any further progression. As far as like low volume disease, less than 3 lesions, I would certainly, based on the STOMP data, I think that trial showed, it was a phase 2 study that showed that it leads to a longer time before they become castrate resistant. And then just thinking about the quality of life, pain, those type of things for patients is a consideration. So less than 3 lesions up front, I would certainly have radiation weigh in for metastasis-directed therapy. But for those with high volume, lower volume, rate responses consolidate in the prostate.
And I think this is where the multidisciplinary approach is so important, because we've had some common patients where you diagnose them and it's maybe 1 or 2 bone mets aside from everything else. And in those patients, we started them on, dual ADT. We'll incorporate metastasis-directed therapy to the 1 to 2 lesions, and then we'll move forward with primary XRT to the prostate based on the Stampede data and those patients having a better progression-free survival, and some with the low volume disease trending a little bit on the overall survival front there.
Right.
So.
Do you also look at other patient factors like PSA doubling time, Gleason grade, when deciding who might be a good candidate for metastasis-directed therapy, or who's going to just blow through it, right? I know that, that's kind of something that I see in my practice, the ones that choose to do metastasis-directed therapy and prefer to be off ADT might be the ones that, are the lower 3+4s, right? They might have a more indolent course versus like Gleason 10. I sometimes feel like I'm playing whack-a-mole with these patients.
Yeah.
What do you think?
No, I agree, and I think we all have these patients in common. Unfortunately, as men, ADT is difficult to tolerate for men, and sometimes they just need a break. And I've counseled patients where if we do directed therapy and we can clear your PSMA PET scan and you get down to essentially a 0 PSA for an extended period of time, I think we would feel more comfortable giving a break or intermittent therapy in that situation. But understanding, counseling the patient that, hey, we are risking higher percentage of progression, but the quality of life factor in that discussion.
All right, great.
Local control is important too when you mention
Yes.
treating the prostate. These guys are probably going to fail, but when they fail and they're having catheter retention or hematuria and all the stuff that comes with locally advanced disease in their prostate fossa, in addition to all the metastatic stuff they're dealing with, I've found treating the primary very helpful in controlling that long term. It's just one less thing they have to deal with while they're going through all of this other stuff.
So yeah, I think that may be a good reason for referral because of, local obstructive symptoms at diagnosis, right?
Yeah.
When they recur, they probably will have those similar symptoms. So would that take into consideration when and who you refer for that as well?
Right. I think one of the triplet trials looked at, genitourinary complications, with trying to do a triplet versus doublet, and they found the triplet arm did better, and actually consulting with radiation after, was sort of that differentiator. Yeah.
And finally, just to cap off this conversation, SWOG 1802 is still ongoing. So this is actually looking at consolidative surgery. What are our surgeons' thoughts about enrolling in this population?
I think that it requires whenever a patient has high-risk disease, first you want to make sure that it's safe, right? You don't want to offer surgery to somebody with locally advanced features, risking something catastrophic happening during the operation. You need to be very upfront about, the potential for urinary gains, but potentially urinary losses, insofar as stress urinary incontinence postoperatively. But many of these men may actually do better from a urinary profile standpoint with having the prostate removed. And they have to understand what they're getting themselves into. That this is not you're going through a procedure that is not likely to be will not be curative, but may help with progression of disease. So I would enter into that conversation very selectively, very cautiously, and very case dependent.
Anything to add, James?
Yeah, no, I agree that it's a very niche part of management of those patients, at least in my practice, because to Wes's point, I have to feel like, and the patient has to feel like we're doing something positive for them. There's a lot of negatives that come with surgery, specifically urinary control, right? So if I'm just going to make the guy incontinent, in addition to all the other treatments he's going to have to be, and we don't gain anything from that, then I'm not going to offer it. Occasionally you see these guys that have had favorable intermediate risk prostate cancer, and they've elected for upfront radiotherapy, and then they'll recur in their pelvic nodes. And so sometimes those guys will say, well, can't you just go remove the nodes? And maybe in some of those patients, you can help them and clear their nodes. But even in node-positive prostate cancer that we're treating surgically up front, then maybe about 30% of those patients are cured with nodal dissection. So you really have to have a really serious expectation setting with those patients, because you don't want to sell them a cure that you more than likely won't reach.
Right. For sure. Did you have something to say?
Oh, no, just like you said, it's difficult because all these patients are living longer with the therapies that we're able to offer. And so quality of life issues are very important, I think, at least, how much can they tolerate certain treatments or whatever interventions we offer, and what are the drawbacks and pros and cons. Like you said, expectation setting, not only for the patient, but for ourselves as well.